Okay. Is everyone seeing it? All right, great. Okay, 1 minute. We currently have about 22 folks in the waiting room. All right, we're right at 1:30, so I'll go ahead and admit everyone and get us started. And good luck, everyone. Okay. Hello to everyone that you all joined in. Welcome. Going to give it a few seconds to allow more of our folks to jump on, and then I'll go ahead and get us started. Okay. See, numbers are still creeping, but I'll go ahead and jump in just for the sake of time. So again, welcome everyone. We thank you all for joining us today, and we welcome you to today's session on CCBHC and care coordination strategies and approaches in our new demo series. We welcome you in. So my name is Dara Lemon, project coordinator here with the National Council. So I'll go ahead and get us started. But before I jump into our housekeeping slides, just want to set the tone for today's discussion. We understand that there are lots of changes going on at the federal policy level and that you all may have many questions about these changes. While you're welcome to share your questions with us today, we may not have answers to specific questions about the policy changes, but we want to let you all know that we are committed to our mission to making mental well-being a reality for everyone everywhere. And with that, I'll go ahead and jump into our disclaimer for today. So just a reminder also that this session is not a CMS or SAMHSA funded or sponsored event. While this session is intended to provide context and information, the National Council team and presenters are unable to answer any questions or inquiries on behalf of SAMHSA or CMS. We ask that you direct any questions to your funding or project officer. Okay, so if you all would benefit from closed captioning today, as always, we do have that available. So in the bottom toolbar of your Zoom screen, you'll see the CC live transcript symbol, which is described here. So if you click that, that will be your way of enabling your closed captioning for today. As well, we do have the chat open and welcome to all of your questions. So we do encourage you all to ask any questions that you have throughout the session, and we will be available to answer those throughout the session, as well as our Q&A at the end of today's session. Okay, so just some quick logistics. We do ask that if you could change your names to include your organization name, which can be done using the three dots in the top right of your Zoom video. If you click that dot, a drop-down menu will drop down and you can click on rename to include your organization's name as well as your first and last name. We do also ask that if you're able to, that you join by video just so we can put faces to names, but we do understand if you're not able to, and it is not required. And with that, I'll go ahead and pass things over to Brian.
Great. Thank you so much, Dara. Really appreciate the introduction and all the housekeeping items. Thank you, everybody, for joining us today. It's great to have you all here. This session, as Dara was saying, is not a CMS or SAMHSA-funded session. This is funded via the National Council CCBHC Success Center. Our Success Center often fills gaps left by other TA centers that may have a more narrow focus or where limitations may exist. Next slide, please. And my name is Brian Mallow. I'm a senior advisor for CCBHCs here at the National Council. And prior to my time coming to the National Council, I've spent most of my career on the provider side and was previously an evaluation director and a CCBHC project director across a few clinics. And with that, I have some wonderful colleagues here today that are incredibly knowledgeable in the space of care coordination. And I'll allow them to introduce themselves. I'll pass it over to you, Laura.
Excellent. Thank you so much, Brian and Tara. And hello, everyone. I'm Dr. Laura Leone. I am a lead consultant here at the National Council for Mental Wellbeing. I have worked in many different roles over my years, and working for the National Council, I have the pleasure and honor of working with a lot of different CCBHCs and organizations trying to stand up becoming a CCBHC. And so I hope to bring that expertise to today. I really focus a lot around care coordination, care management, and a variety of other topics for our consultation. Thank you so much. And Samantha, I'll turn it to you.
Thank you so much. My name is Samantha Wolverton. I am the Integrated Health Outcomes Coordinator here over at Fort County Mental Health Center. I came into my position about a month before we transitioned into CCBHC, and I've spent about the last 6 years building care coordination within our CCBHC in rural and frontier areas.
That sounds great. Thank you so much for those introductions. I'm so excited to have both of you here today. I'm really looking forward to this session. Next slide, please. And here we can take just a quick look at our agenda for today. We will be looking at the definition of care coordination and criteria requirements, goals and mechanisms, as well as measurement for care coordination, approaches and practices for care coordination. We'll have a CCBHC showcase from Sam on Fort County Mental Health Center Incorporated. Assuming we have time, which we should, we'll have a breakout rooms and some discussion towards the end, and then we'll wrap up. And next slide, please. And here we have a few learning objectives for today to increase knowledge of care coordination criteria and to define care coordination, to identify common strategies and approaches that clinics use to coordinate care, and to recognize different care coordination models that CCBHCs may utilize. Next slide, please. And as always, if you've attended any of our new demo learning sessions previously, we always like to do some quick polls. Today, we just want to find out what's your CCBHC status and what is your role at your organization. So just briefly take a few seconds to identify the option that best fits for your clinic and for your role. And once we hit everybody, we'll take a quick look at the results. We usually tend to have a few established demonstration CCBHCs in the room, along with maybe some new demo CCBHCs from one of the 10 states that was announced back in June of 2024, as well as some grantees that are looking to get into the demonstration here in the near future. How are we doing on responses, Dara?
Pretty good. Still have a few rolling in,
Okay,
but it looks like it's slowing down. Okay, so I'll go ahead and share.
that looks great. And can everybody see the results? Looks like we have about 20% new CCBHC demo site, no current or previous grant. About the same for new demo sites that are also a current grantee. Maybe one or two that are a new demo site and a past grantee, but not a current. Quite a few established CCBHCs that are demos in the room. Thank you for joining us today, experienced folks. And then as we look down at the roles within the organization, really a nice spread here of we got CCBHC program directors, executive leadership, other management and administration folks, a nice mix of some clinical and mental health or SUD specialists and other professionals, and then some other folks around peer support, got some care coordinators here in the room, and always at least one data or evaluation person. Great. And oh, missed the finance. There always at least one finance person in the room. We don't know who that is, but we love having you here. And with that, I think we can move on to the next slide. And right on past the title slide. That works perfectly. So first, we're going to look at defining care coordination. We talk about care coordination being the linchpin of the CCBHC model. I won't go into too much on that because I think you're going to talk about that a little bit later, Laura. But it's such an important component to ensure that the model can do what it is intended to increase access, improve quality and outcomes, and care coordination is one of the most important ways that we can make that happen. But care coordination involves the deliberate organizing of individual care activities and sharing information among all participants concerned with that individual's care in order to achieve safer and more effective care. While at the same time, the individual's needs and preferences are known ahead of time and communicated at the right time to the right people, and that this information is used to provide safe, appropriate, and effective care. Next slide, please. And we'll take a brief look and do an overview of the Section 3 care coordination certification criteria. Later, we will provide a link to an on-demand lesson that will go into more detail if that's what you're looking for today. And we'll share that when we get towards the end of the certification slides. But this first one, when I think about care coordination, I always think about this slide and this information first. A CCBHC must coordinate care across the spectrum of health and human services, and that is based on a person and family-centered treatment plan. This must include not only behavioral health, but also physical health. And it must address social determinants of health as well, including other social services, housing, educational systems, and employment opportunities that are necessary for the recovery of the whole person. And then third, we must also coordinate care with systems to meet the needs of individuals, including criminal and juvenile justice, as well as child welfare. Next slide, please. And then as we continue to look at 3A, it goes on to say that the CCBHC needs to assist people receiving services referred to external resources in obtaining an appointment and tracking participation and closing the loop on those referrals to ensure that services are coordinated well. And this is probably going to look different for one individual, maybe mild to moderate symptoms versus an individual with severe and persistent mental illness, as far as how much you support them and how far you go in supporting them to obtain that external appointment and how you are going about closing the loop and coordinating care. The CCBHC also needs to coordinate care based on the preferences and needs of the individual, including in the event of any psychiatric or substance use crisis. And the CCBHC develops a crisis plan with each individual receiving services. The clinic also needs to counsel individuals in care about the use of 988 and other call-in services, including accessing mobile crisis and stabilization services. And then finally, under 3A, is that CCBHCs need to assist all people in accessing benefits, and that includes Medicaid and all other supports that would be beneficial to the person and their recovery. Next slide, please. So with that, we move into 3B, care coordination and other health information systems. And this is heavily focused on the technology that you use. The health information technology, and particularly we often just talk about this as our electronic health record or electronic medical record, but CCBHCs must have this. It's pretty straightforward to have that. Pretty much every CCBHC does when they go to obtain certification status. But then this next line around CCBHCs use the HIT to conduct activities including population health management, quality improvement, reducing disparities, outreach, and research. That's like a really heavy hitting line. There's a lot going on there that if you just miss this one criteria, it's easy to forget about some of these things. And we probably talk about CQI a lot more in section 5 of the criteria, but it's absolutely integral to the care coordination process and all of the work that's being done. 3B also states that CCBHCs should use HHS adopted standards to enable HIE or Health Information Exchange, and that the technology is certified under the ONC. Does it capture health information? Does it support care coordination? Does it provide evidence-based clinical decision-making? and support. And, that probably looks really different. Some EHRs are really well set up for that, and have dashboards and reporting functions built out as part of the EHR. And others will need to work with their IT department to build those things out separately from whatever the EHR includes. So just important to note that. Next slide, please. And then as we continue to look at 3B, CCBHCs also need to work with DCOs very closely to ensure a number of things. One, to ensure confidentiality regs are met and privacy is upheld. Need to focus on improving care coordination with DCOs, including health information technology, including support for health information exchange. So if you have a DCO, you can see here that the language says that within 2 years you need to have a plan, but really that plan should be in place as soon as possible, and something that is being worked on to improve continuously how you're working together, kind of all the time. I know for me, in my experience, that was done through our very formal monthly continuous quality improvement process, and that was the best place for us to improve that over time. And then lastly here, CCBHCs need to work with DCOs to integrate clinically relevant treatment records generated by the DCO and incorporate those into the CCBHC health record. And that's sometimes a piece that some clinics don't have in place initially, but build over time. And obviously speaks to how important or how helpful having that data and information in the direct CCBHC's EHR is to supporting all things care coordination. Next slide, please. I love this one. So I love 3C because it is so straightforward. When I'm working one-on-one with clinics and there's any confusion around partnerships, what's a DCO, what isn't a DCO, if there's any confusion around those two types of partnerships, I usually bring up the criteria and I just share my screen and I walk through what we're going to look at right here. Is there are required partnerships that are laid out first. Organizations such as FQHCs, hospitals, inpatient facilities, substance use detox, post-detox step down. And then next slide, please. The other partnerships listed under 3C are often talked about as additional recommended partnerships. I think, this is really based on the population that you're serving, as far as if you have or need to have a formal agreement of some kind with them, the needs and preferences of individuals that you're serving, and or the needs identified within your community needs assessment. So these are really common service areas that CCBHCs often have formal partnerships with, indicating what services each entity provides and how the two organizations are going to coordinate care. Next slide, please. And so that brings us to 3D, the final subsection of care coordination under section 3, care treatment team, treatment planning, and care coordination activities. So number one, all treatment planning and care coordination needs to be person-centered and family-centered. The clinic treatment team includes individuals receiving services and their family caregiver, which we pretty much are always talking about, but sometimes we might forget about other support system individuals in that person's life. So I always like to highlight that here. And then lastly, the CCBHC also has an interdisciplinary treatment team that's responsible for directing and coordinating care. This team comprises individuals who work together to provide whole person care. This includes medical, psychiatric, psychosocial, emotional, therapeutic, and recovery supports. And this can be done in different ways, and I'm really looking forward to hearing from our other presenters in just a few minutes to hear about best practices, approaches, and how this is being done at Fort County. Next slide, please. And here, very briefly, we just want to highlight, obviously these are the criteria. They must be met to be certified as a CCBHC, but there's some really big and important benefits of care coordination that aren't, explicitly listed in the criteria. We have the triple aim, which is to enhance patient experience and satisfaction, to improve population health and outcomes, and reducing the per capita cost of care. These are all outcomes and benefits of coordinating care successfully in your clinics. And then on top of that, we also see the addition of increased provider satisfaction. Well, I think it was last month that we talked about workforce innovations and increased provider satisfaction goes such a long way in retaining staff that are already employed by your organization, but also speaks to recruitment as well. Next slide, please. And here we're going to look at goals, mechanisms, and measurement for successful care coordination. So the National Quality Strategy has identified 3 long-term goals related to care coordination, and we see those here. Number 1, improve the quality of care transitions and communication across settings. 2, improve the quality of life for individuals with chronic illness by following a care plan that anticipates and addresses symptom management, psychosocial needs, and functional status. Then number 3, establish shared accountability and integration of communities and healthcare systems to improve quality of care and to reduce health disparities. I really like coming back to these 3 long-term goals. If I ever need grounding or regrounding in the care coordination space, particularly when it comes to expectations and goals. So I just wanted to share this with all of you today, and hopefully you find that helpful as well. Next slide, please. I also think it's really important to remember both core and broad care coordination activities. I know in my experience, it's been really easy to kind of get sucked into just one type or the other, depending on what my role has looked like, and that's changed over time. So I think it's helped me to think about these things, separately and broadly, and as well as like how it all kind of like functions and works together. So try to keep this stuff in mind as you hear more from Laura and Sam here in just a minute or two. Next slide, please. And here we're looking at measuring effective care coordination. As a former evaluator and just all around detail-oriented person, I'm always thinking about data and measuring things. So again, as you hear from Laura and Sam today, keep thinking about how you currently measure or could be doing, improve how you measure your care coordination activities within your clinic and determine if care coordination approach that you're using is achieving success and what that success looks like. So all of these options that are listed here are inherent to the CCBHC model. And some, like the first one listed, transitions of care, is directly related to, or really is a direct like quality measure under the state measures. How long did it take to connect with an individual post-discharge from an inpatient stay? That is a state measure. And with that, your clinic can be benchmarked against all others as these are consistent quantitative measures. So again, keep that in mind, these different ways of measuring effective care coordination as you hear from the other presenters. And I think with that, I'm passing it over to you, Laura.
Great. Thank you so much. And, I'd love to dig in deeper now into the mechanisms and the actions, especially that Brian just discussed. But to first do that, though, I'd like to take a step back from care coordination and provide a little bit more clarity in the related to the terms of care management versus case management. So if we can go into the next slide. These terms they get used often. It can get confusing. So for clarity here, and I will expand upon the fact that things have really morphed over time, but case management is really a time-limited assistance for concrete needs and utilization of resources. And historically, that has focused a lot around the various aspects of just health overall and well-being overall that people are connected to, whether that's related to their finances, their transportation, whether they needed certain durable medical equipment, and so on. And then sort of entered into the system this newer term here of care management. And care management, and Brian had shared a wonderful definition of that earlier, but another simplified way of putting it is really the practice and the process over time to achieve person-centered goals and outcomes. Really thinking about how we help clients to expand upon, yes, they might need those concrete needs and resources, but how do we over time ensure that they get engaged into various aspects of care that's needed? How do we help them to maintain into the system so they're not falling through the gaps or the cracks? How are we ensuring that we understand what that person's goals around their own healthcare and well-being are? How do we connect that, help provide education and support, and continue that process for them over time? So these terms have commonly been used interchangeably. And I will talk a little bit further in a few minutes about, not worrying so much if maybe you hold the term or title of a case manager, but you're doing care management or reverse. We'll talk about that a little bit further. But really thinking about these aspects within care management that Brian was talking about around care coordination and also care transition and transition management and how that happens. Really thinking about how we just really help connect people and help them to remain in the systems and care at large. So let's go on to the next slide, please. And I have a question for all of you, or questions really, and I'm going to go ahead and put them into the chat so you can see them, but also just ask, just pause for a second and think about when you or your family need healthcare. What do you hope that care is like? Or when you have received care, what worked and what didn't work? Feel free, go ahead, put those thoughts into the chat. If anyone would like to unmute, I welcome you to unmute and share now. What are those aspects and things that really stand out to you around what you hope the care is like? What works is providers that follow through on what they say, and yes, and having an ease of access, that care is timely, that it's trauma informed, that there's follow-up in a variety of different ways. Ideally, that the service can be quick if it doesn't need something that is complicated, that it's welcoming, that you feel listened to and confident of the staff person, that they're competent. I'm just reading out loud the great things in the chat. Yes, that people are knowledgeable, that they communicate not only with you or your family members, but with each other. Person-centered, just really thinking about the various aspects, access to care and friendly, no hidden fees, that it's competent. These are great call outs. And these call outs are all the things that we really want to encompass in care and interface with care management and care coordination. Everything that has been discussed is something that we want good care to be. And so if we can go on to the next slide. And thank you all for sharing in the chat. Really appreciate it. But everything that was highlighted really covers the gamut of what's sort of here and represented on this slide. And these are the things we're pulling forward, the framework that we're really working within when we think about care coordination, when we think about all the different kinds of approaches and practices that we're using. We want to think about family and community connections. Just as Brian called out earlier, people are coming for services and they are representing themselves, their family members, their friends, and they are often in wanting to include those people in their care, right? We're thinking about just the supports that people have in their life or the lack of support that they have in their life, and how we have an opportunity to help foster and build that with them, for them. Really thinking about how do we connect people to other supports so that they can thrive and continue on. So that family and community connections, and really thinking about the support networks that people have is a part of the work that we do. And understanding too, that it doesn't have to be a variety of different people in somebody's life, that one or two meaningful connections can make a world of difference for somebody and have such a positive impact on their health outcomes. Going forward and thinking about sort of the next area that we want to pull forward in the framework, and again, many things that were highlighted in the chat here, right, are really thinking about how we have a recovery and resilience framework or practice. The definition that I really love to use for recovery is thinking about recovery, meaning that we are pursuing a fulfilling life regardless of the difficulties that one has faced, and can involve the development of or continued enhancement of a positive identity, as well as personally meaningful connections in one's community. Again, those connection pieces. And it can be facilitated by relationships and environments that promote hope, empowerment, choices, opportunities, all that support people in reaching their full potential as individuals and community members. And that definition comes out of the Philadelphia Department of Health, and I love it. And I really think speaks to the fact that sometimes we use recovery as only a term connected to substance use, but it's really ideally connected to all facets of health and well-being. So really thinking about our mental health, the recovery of mental health, the recovery of substance use, the recovery of the various, social determinants that exist, and so on. So really thinking about being able to encompass all of that, and then lending into resiliency and resiliency building. So in resilience is essentially the ability to adapt when faced with adversity or when faced with significant amounts of stress, and to return to your equilibrium, or sometimes it's kind of returning to maybe a new baseline of way of being for people. And the beauty is that everyone has resilience and the capacity to grow that resiliency. So thinking and blending that in to what we do and what we envision for care coordination is a part. Trauma-informed care was another thing that was called out very directly and also indirectly in the chat from suggestions of all of you, and really thinking about being trauma-informed understands and recognizes that people face all sorts of traumatic, adverse experiences in life. And we can go ahead and assume that every one of us has probably experienced some of that, up in like about 67% of us before the age of 18, never mind beyond the age of our youth years, what we're experiencing. And so how do we approach and interact with each other if we take that automatic assumption? How do we build information into the way that we practice, into the way that we interact, how we establish the physical surroundings? All of that goes into being trauma informed. And it's not just about treating trauma. It's about how, it can represent other terms that we often use and know work really well. Good communication, respect, good customer service. All of those things are other terms that we can bake in or think about that are connected to being trauma informed. And so it doesn't matter if your organization, sort of what your organization focuses on, right? Any organization, place can be trauma informed. Any person can be trauma informed, and so on. So really thinking through and then leaning into sort of this last or fourth pillar here of whole health, wellness, and integrated care practices is about how we recognize and treat the whole person and the context in which somebody is in, instead of bits and pieces of a person in a very siloed way. Right? Historically, care has happened across multiple settings, across all sorts of different staff or providers that never talk or interact with one another. And so many of you, again, called out in the chat how it is so vital that those people talk to each other and talk with that client. It is not done, these things are not done to somebody or at them, it's with them. And really thinking about that team-based care approach and that whole person care approach. How do we help do that? It doesn't mean each of our organizations has to represent all of the care kind of continuum or spectrum. But how do we help facilitate that for individuals? And that, again, comes and happens with care coordination. So all within and underneath here is care coordination, just general practices around care management, and a call out again to Brian's comments around measurement-based care, and really thinking about how we can use information, data, it's just another term for data, but information to gather and to know, is what we're doing helping? Are the practices that we have in place, are the operations that we have in place working? Or are they not working? What can we learn from that? What can we do? How do we pull that forward? How do we share information directly with our clients so that they stay informed, so they feel empowered in their own healthcare to be drivers in their own healthcare? And all of that includes a blend of a variety of different practices, evidence-based practices. And I've listed here some, but not certainly representative of everything, but pulling forward practices such as how we communicate and how we help people, specifically with change or growth or decision making, right? When we think about the use of motivational interviewing, the use of shared decision making, other evidence-based practices that specialize in different kinds of maybe problem areas or diagnoses, things like problem-solving treatment or behavioral activation, if you're working with somebody with depression, just as an example. So lots of different things here. And we want to blend and pull this forward. This all encompasses what we do within care coordination, and care management at large. If we go on to the next slide, we can think about the various aspects or activities that happen here. So screening and assessment and using data, right? So thinking about how do we either screen or assess for different kinds of needs. And we often do this sort of thinking about it from a problem perspective, right? So giving sort of a needs assessment, a screening tool that assesses any particular problem areas that somebody might have. There are also many screening tools that exist that are out there that look at also strengths. And so I want to just call that out as a way to lean into also assessing for strengths and being able to leverage those pieces when we're working with individuals. But it usually starts with screening and assessment to understand what somebody's needs are around what they need to focus in care, what they need, maybe the work and what will be built into the treatment plan will encompass. All of that happens from first gathering of information, synthesizing that with other pieces of information that maybe get shared from various people within that person's support network, observations that we make, and so on. And we synthesize that into our care planning, treatment planning, care planning. We call these things different terms depending on our roles and our functions, but that process of coming together with your client to understand what their goals are is a part of the piece. And a callback to what I was talking about before with whole person health is really thinking about, how do we know and understand all of the various goals that a client has, all of their various needs, even if it's not something we are going to directly be helping them with or we have particular expertise in. Maybe that's somebody else on that person's care team, and maybe that person in their care team is from a designated collaborating organization, or another community space in the area that you work within. How do we think about and share that information? How do we talk with the client about sharing that information so it gets recognized and honored in the overall vision and care of what care coordination can be for that person? We might not be doing the direct work, but then we're thinking about how do we facilitate and ensure that that client is still staying connected to that work and those needs are getting addressed. So a lot that comes under care planning, and in an amazing world, we would have everyone as part of somebody's care team having access to that care plan, that treatment plan, that service plan. And unfortunately, there are limitations around how we do that and how well that happens. So when we think about care coordination, when somebody has the role of, let's say, a care coordinator, they are often communicating and facilitating what is on that care plan and making sure that all the various team members kind of know and understand that. Continuing on here to really think about all the different actions that encompass care management, we also have increasing health literacy. Really thinking about how health literacy is the understanding of health-related information and terms, and more specifically, for each individual person, for them to understand their own health care. We can do that and help that in a variety of different ways, thinking about the language that we use, and that the recognition that we do not have to use all sorts of fancy terminology in order to express what needs to be done or what kind of care is happening, right? We can, I can say to somebody, we're going to work on cognitive restructuring today. Or I can say, today we're going to talk about how we can think about changing the way you think. And it means the same thing. And one is a little bit more in everyday language. So really thinking about how we can shift the language that we use. There's not a need, even in our writing, to have fancy, complex language anymore. Payers don't require it anymore. It's really sort of something that is antiquated in the way that we maybe historically have worked, that we're shifting away from, and really thinking about how do we make care as clear and upfront, as user-friendly as possible, right? So that this is not the Wizard of Oz. There's no man behind the curtain. We want things to be transparent and upfront for our clients, and so that they can, again, be drivers in their own healthcare. And the first way to do that is to understand. You're going to learn to drive a car. You want to understand what that vehicle is and how to operate it and all the pieces to it, right? And that's part of this process. Medication management and adherence support is really how, again, our role, individual roles, maybe, you're not a prescriber in any way, and we want to recognize and honor the expertise of our various team members, and always ensure that those people with the expertise are interfacing it or talking with our clients. But we also can support that process for our clients, checking in with them about how it's going. If they do have a particular medication or medications that they have to take, what is that process like for them? Are there any barriers that are getting in the way? Is there any confusion that happens, right? That thinking about that support that we can provide around adherence. In my experience, and I'm shifting away from language like medication compliant and really shifting instead to thinking about it again as adherence, because people don't just like wake up in the day and be like, got to be non-compliant today. It's like a good day, right? Like, no, just other things get in the way of things like taking our medication or otherwise. So really thinking about and creatively supporting somebody in that process, and remembering people have the right to autonomy and their own decisions and so on. So all of that plays a role too in care management. Risk stratification is a fancy jargon term for how we understand people's varying levels of need or risk depending on their particular diagnoses, depending on their topics, right? Somebody who has a low level of depression versus a moderate versus a high, those, we're going to do something different for somebody with a low level of depression than we would for somebody with a high level of depression or asthma or hypertension or so on. So really thinking about how do we diversify what we do so that it really maximizes the needs of somebody in that efficiency. Again, a great call out. So many of you highlighted this aspect of care, efficient care, timely care, and making sure that what the person needs is what's happening. And all of that goes into understanding the levels of risk or the level of severity based on any particular topic or need somebody has. And it lends also to this population management aspect, which is understanding people by groups, understanding groups and how we kind of think about people in terms of maybe where they live, in terms of particular diagnoses that they have. How do we ensure that the staff people have certain levels of education and expertise around various topics that are coming up for the population served within the community. Excuse me. And the last sort of call out here is a big one, which all about care management really encompasses the coordination aspects and the management of care transitions, and really thinking about what that goes into, what goes into care transitions. So care coordination is really, again, another way of thinking about organizing and directing and coordinating all of these different aspects or call outs, and ensuring that the person is getting what they need, and staying within the care that they're hopefully getting delivered with them. Care transitions is also about recognizing that we may not in our setting be able to establish all of the care that is needed for that person, or a particular area of care that is needed. And so how do we ensure and make those connections for somebody? Next slide. So there's a call out here of understanding that care coordination and all these different aspects that I've talked about can be somebody's role, or it can be a function of somebody's role. And this is also sort of a callback to my earlier mention of the differences between case management versus care management. So we can have individuals in any particular organization whose role it is to be, let's say, a care coordinator, or a care manager. There's all sorts of different terms, patient navigator. There's so many different kinds of titles that people can be given. You can be a I'm just trying to think of other terms. Well, you get the picture. So somebody's role might be to do all of the care coordination aspects that I've talked about, or we've talked about so far, the activities. Or somebody could be in a different role, a diabetes educator, a peer specialist, a case manager, a primary care provider, insert a therapist, and be providing care coordination. Yes, a nurse navigator. Exactly, Brian. So really thinking about, it doesn't matter what your title is, right? What your role is, you could still be functionally providing care coordination and care management. That in and of itself also gets a little tricky. That's why sometimes the terms between case management and care management get confused. It also gets tricky around understanding, well, and who exactly is doing all of this. Some of that is a discussion that in your teams you need to have around what aspects of care coordination, if we kind of think back to the slide before, of all the various things that are happening, what aspects of that does maybe somebody who is in a very specific role of care coordinator, what are they going to do or follow up or oversee, versus the other members of the team who may also be establishing and providing care coordination, and what they're going to do, right? So that we don't have a duplication of effort. And so that entails communication and an understanding within teams, within programs, departments, organizations as a whole. So really thinking about care coordination sometimes is sort of like the front door of services. Like, how do we help engage somebody? How do we provide entry into services? You want to think about the team-based care coordination aspects of who is accountable and for what. You want to think about it as a layered approach. Everyone's got their different specialties, and how are they going to share in this process, and really addressing medical or physical healthcare needs, mental health care needs, substance use needs of prevention and wellness, and so on. Next slide. So a call out, Brian said, I would be talking about the linchpin a little bit more here. And for anyone who wanted to know what a linchpin looks like, it is that pin in the middle of that wheel right there. We say care coordination is the sort of linchpin of care. And what do we mean by that? It plays a central, crucial, and pivotal role in ensuring the success of a broader healthcare or service delivery system. So care coordination is seen as that key element that keeps the various parts of healthcare services and support systems interconnected and hopefully running smoothly, right? Like that wheel is going to stay on that axle and that axle is going to move that wagon or whatever it is. Thinking about things like systems and discrimination, symptoms, complexity, all of that get in the way of people receiving care, the care that they need. Care coordination can really provide the needed expertise, support, guidance, and advocacy to help with this navigation and understanding. And for too long, even within our own organizations, we have been siloed and the left hand hasn't known what the right hand was doing. So we're really looking at part of care coordination in the doing of this, whether it's a role or a function of somebody's role, is to think about how do we connect team members and services. So ensuring that all healthcare providers, team members work together, communicating effectively. This is especially important for our clients with complex chronic conditions who may see, again, multiple providers or different staff people. And without coordination, there is a risk of fragmented care, missed appointments, or conflicting treatment plans. Improving outcomes. So really thinking about effective care coordination can lead to better client outcomes by ensuring timely, appropriate care and reducing unnecessary hospitalizations, readmissions, or medical errors, right? People unnecessarily jumping through hoops that they don't have to jump through. It helps prevent all those care gaps that people can unfortunately fall into, and ensures that clients receive the right treatment at the right time. Again, a great call out for many of you in the chat, calling out that that's the kind of care that you're looking for and that you would want for yourself, for your family members. Excuse me. And enhancing client experience, by coordinating care, the client's experience hopefully is that there's less confusion and frustration as they don't have to ideally manage multiple appointments, follow-ups, or instructions, especially on their own, right? We're partnering with them in this process. And they can have a central point of contact, especially if somebody is in a care coordination role. So if somebody is functionally and in their role, a care coordinator, that person often serves as a great contact to help them navigate the system. I don't want to take it away that it does not have to be your role in order to help somebody to do that, though, right? Again, it can be a function of your role as a nurse navigator or as, a case manager and so on. So the last call out here is about cost efficiency. So thinking about proper coordination can reduce unnecessary tests and hospital stays and duplication of services, ensuring that everyone involved in the client's care is on the same page. So care coordination can help lower overall healthcare costs and so on. And again, it's a call out to something that Brian was talking about earlier. And so in a scenario where you have a client who has multiple health issues, maybe they have diabetes or heart disease, or arthritis, right? Like care coordination ensures that the endocrinologist and the cardiologist and the rheumatologist and are all aware of each other's treatment and medication prescriptions and so on, right? When as a CCBHC, we want to ensure that all the proper people, whether they're internal to our organization or external, as long as they're interfacing with the client, they're a part of that team, that they're connected and stay connected. Now, all of that takes a lot of effort and energy. So there's going to be variances in how much care coordination each client gets at any given point. And so having team discussions and understanding around who, especially in our client population, needs to have stronger or more substantial care coordination than others also is something that needs to be discussed. Often people with higher levels of risk associated with their care or their conditions, multiple, again, chronic conditions and needs, maybe people who are at a higher risk of falling falling out of care. You really want to think about and have some team conversations and understanding around when maybe somebody whose role it is to be a care coordinator is going to provide that oversight and care coordination aspects versus maybe another team member whose part of their function of their role might be to do care coordination. Again, the planning of that. So calling care coordination the linchpin really underlines its importance of maintaining that integrity of the entire healthcare process and making sure all aspects of that client care are properly connected and managed. So going to the next slide here. Really thinking through transitions of care, there are many different transitions of care that each one of us makes in our lifetime. So we're really wanting to think about care coordination is when we can really help somebody through that process. A client moves from one setting of care to another, across settings, in between settings, within those settings, and so on. Whether the setting is a hospital, whether it's the pharmacy, whether it's a substance use treatment center, and so on. There are all sorts of different places that people are going to receive care, some which are going to be ongoing and long-term, some that are short-term, or intermediate places, like if we're seeing somebody on an outpatient basis and then they need inpatient hospitalization for a stay. All of that, we call that aspect of transitioning in and out of and between care a piece of care coordination that really does deserve follow through and clear communication. When communication is clear, we can be up as upfront as possible in helping somebody to make those transitions. We can help to reduce those unnecessary hoops that people jump through. Closing the loop is something that we called out earlier. Really thinking about if we're going to refer somebody elsewhere for care and they're going to remain in care there and maybe no longer return to our care, then how are we ensuring that they truly got to where they're going? How did we help facilitate that process? What were the conversations in mind, and is that person now established? People or places sometimes make referrals without taking that extra step of ensuring that the person got to where they're going and they're now connected. So we really want to ensure that that's happening. And even when somebody is not fully transferring out of our care and into another place, again, like an example, like the hospital, and they may return to our care, how do we ensure that that return to care is going to be smooth? Are we staying informed of information? Are there certain consents and sharing of details in place to make sure that the person really gets, again, that's those smooth transitions that we hope for? All of that really leads into the communication aspects. And so if we think about and go on to the next slide here, team communication and how teams and people function with one another I cannot underscore enough the importance of this. This is bigger than just care coordination and providing care management, but we really want to think about how we use person-centered language, how we communicate information over team meetings, whether we have daily huddles, how we use our electronic health records and emailing systems and messaging systems to communicate with one another, and also how we do warm handoffs. The term warm handoff gets used very often. And so to very much define what that means, a true warm handoff, how it is intended, means that in real time, one person, what we'll say, one staff person is introducing another person, another entity, another staff person to the client in real time. Whether they're physically in the same room together, whether they're virtually in the same space, or whether they're over the phone at the same time, it is all happening in real time together. It is not when you say, oh, please, I would love for you to meet with my colleague, Brian. He's just down the hall, 3 doors down. I'll let him know you're coming. And then you let the client leave your office and hope that they get to Brian's office. That is not a true warm handoff. So we want to really think about, maybe that's like a lukewarm handoff or like a colder hair? I know, semantics of the language, but we want to think about, when do we especially want individuals to get a warm handoff? We can't do it for every single person at every single time. So again, having a team conversation and understanding who are we especially wanting to ensure that they get those true in real time connections. How are we going to make sort of an establish an understanding of who is especially going to get that? Are they going to be our clients who I don't know, have particular diagnoses or needs? Are they going to be, again, people who tend to disengage or fall through the cracks, so on and so forth, right? Having an understanding of that and who we're going to do that for helps ensure that we can make those sort of risk stratification decisions of, when people have a certain level of severity or need, we are especially going to meet their needs with doing these things. So thinking about and talking about warm handoffs versus other kinds of referrals or handoffs is important. And we do know that, like, just handing a piece of paper and saying, please call this person, right, to a client, that often does not help, does not work. So any way we can facilitate those referrals and then follow up and ensure that that's happening goes such a long way to that person establishing and engaging in care and services that they need. We also really want to think about the partnerships that we build. It's not just about the work, again, that we're doing internal to our own organization. It's about those other community partnerships that we have, people like other organizations that maybe are designated collaborating organizations. How do we ensure that they have an understanding of our practices? How do we ensure that we have an understanding of theirs? How do we stay in constant communication about all of that? Goes into aspects of care coordination. It's so much about what we do is about relationship and about all the various opportunities for communication and ensuring that the client is a part of that, right? Again, not happening to them or at them, it's with them. So if we go into our next slide here, before I kind of turn it over to Samantha, I just want to kind of call out, we want to really think about how do we ensure that our clients are really involved in this person-centered approach, right? That they have a voice and choice, they have an understanding of what's happening. Really a call out to not only how we do this in our individual care with people, but also how we collectively assess how we're doing in our care overall, using things like our advisory groups or advisory councils and so on. How do we think about that tracking of what we're doing in care coordination to know what we're doing is working and working well, and learning from that, right? If we're kind of tracking how many warm handoffs we're doing, and then out of those warm handoffs, how many people established care with that next entity that we did the handoff to and remained in that care, right? Like, if we're actually tracking that, we can know, like, are our warm handoffs working, or do we have to change something about that? Or how many people are we actually able to do a warm handoff with, just as, all as examples. Baking in the tracking and trending of these different kinds of tasks from the start helps ensure we do it well, do it effectively. We learn from when we're not doing well, which is so important too. And it establishes sustainability over time. Really thinking about that data and not being afraid to collect that information. And again, we're not going to collect it on everything all the time, but ensuring that that's happening and from the very beginning really helps to provide successful care coordination, among other things. And we want to also pay special attention to, people using the emergency room or going to the emergency department for both behavioral health and physical health care needs, right? Helping to establish care for those individuals who might be using the emergency department as their de facto care, people being hospitalized for either mental health, substance use, or physical health care needs, and that we maybe could have prevented certain hospitalizations from occurring. We want to ensure that people, when they're being discharged and maybe returning back to our care, that those discharges are smooth, that we have that developed communication to establish that person back into our care. So again, there's these smooth transitions. I could certainly go on and on and on, but we don't have time for that because we definitely want to hear from Samantha. So I will say next slide, and Samantha, I turn it over to you.
Great. Thank you so much. Thank you for all that wonderful information. A lot of what I'm going to be talking about today actually lines up great. It's a pretty practical application of what y'all have been talking about so far. If we could go and go to the next slide, just to give y'all an idea about where we are. We are in the 5 most southeast counties in Kansas. Despite the name, we do serve 5 counties. And those are going to be Elk, Wilson, Cowley, Chautauqua, and Montgomery. And we have about 6 offices, and we've worked in some satellite offices here as well that aren't exactly indicated on this map. Just to give y'all some context about how rural we are about anywhere between 1 to 3 hours, depending on where you are in the catchment area, from a major city. So like Wichita, Joplin, Tulsa. So we don't have specialists. A lot of times we don't even have primary cares in the communities that we serve. A lot of times the only thing they have is a Dollar General and a gas station. And realistically, with the picture you see up here, if you go 2 miles down the left from the chair I'm setting in right now, you're going to see the exact same thing. So we're working in pretty limited resources. If you'll go ahead and go to the next slide. Just to reinforce this, we do have primarily rural and frontier areas across all 5 counties. We do have some towns, Independence, Coffeyville, Winfield, but most of our primary area is rural or itty-bitty towns. We initially were awarded our CCBHC expansion grant summer of 2020. We had the 2-year grant, and that went through May, summer of 22. During that time, the actual legislation was passed right in about the middle in 21. And we are now currently one of the original 9 CCBHCs in Kansas. Right now, the state is at 25 out of 26. And I'm sure it won't be very long before the next one comes along. And next slide. So with care coordination, actually taking these things and putting them into practice, here's kind of our list of the major things that we did as far as moving into that CCBHC mindset. First thing we did was study the criteria of CCBHC, identify the gaps specifically in care coordination, develop dedicated teams not only to provide care coordination, but also to identify where the gaps were and address concerns. We also created and adopted an internal universal definition of care coordination, what we wanted it to look like for our agency, our population, what was important to our communities. Identify specifically what staff, both new and existing, will be doing the work, because kind of like we were talking about before, if it's everybody's job, it's nobody's job. So being able to specifically note who's responsible for that work and what those expectations of care are for each role. We've also worked to develop workflow and policy. Whenever we initially did it, it was version 1.0. I think everything is probably on about version 3.0 or 3.5. Another big piece of this, and I will say this is especially important because of the area we work in and the lack of resources for those that we serve realistically in our area local, is establishing key partnerships. So we're working to identify needs and working collaboratively with our community to meet the most, really get the most out of the resources we have to meet our clients' needs. And then train, refresh, train again as we go through care coordination and anything CCBHC, because there's always going to be all this information all at once. It's important that we continue to reinforce this information and why we're doing it. Some other important pieces of care coordination for us have been developing data management plans and integrating care coordination into our CQI process, not only as developing individual CQI processes for care coordination, but also coordinating care, integrating care coordination expectations into current positions and developing that into their quality improvement standards as well. Next slide. So first things first was identifying the gaps in care. So our major ones were we were lacking FQHC, inpatient care coordination protocol, Veterans Affairs agreements, MOUs with VA, as well as follow-up protocol related to inpatient ED residential facilities, as well as treatment plans, teams, and planning, and ensuring that those treatment plans are provided in an integrated way. We're wrapping the entire plan and treatment team around that client. I will say, just to note, some of these things we did have kind of expectations around, but we just didn't have those very clearly written policies, expectations, what this looks like in practice, and CQI processes built around them. Next slide. So whenever we first started implementing care coordination into our agency, I'd kind of mentioned before, to help resolve some of those gaps, we developed an internal care coordination definition. And for us, care coordination is it's timely, it addresses whole person needs, improves chronic conditions, and assists with the attainment of patient goals. And those chronic conditions include chronic mental and physical health concerns. It also supports adherence to treatment recommendations. So it engages patient in chronic condition self-care, also engages for their continued engagement in wellness initiatives. Like if we have diabetes, that we have a diabetic diet and we're following expectations for that. If our insurance offers resources to help meet that need, we're helping connect them with that. It also involves coordination and collaboration with other providers to monitor patients' condition, health status, medication, side effect, especially whenever we get into psychiatric medications. Side effects are something we want to definitely keep a close eye on just for safety overall. We engage the patient and also as well as their family, support persons, guardians. This can include friends, neighbors, PCAs, really anybody who's a major support for them in their life and is helping them navigate their healthcare. And this includes decisions related to pain management, palliative care, end-of-life decisions, and just overall supports. We also implement and manage treatment plans through quality metrics, assessment, survey results, service utilization, and then we utilize those to monitor and evaluate intervention impact, and then change our plans according to how interventions are going, progress we're making with client. And then the last piece of care coordination, especially for our agency and especially in the area we're in, is that we create and promote linkages to other agencies, services, and supports. And next slide. Thank you. So what this looks like in practice, this is probably 1/100th of what care coordination looks like in practice whenever we get to the actual specific process and activities. However, some of the bigger things are going to be staffings, treatment teams, wraparound meetings, which are what we name there are post-hospitalization, post-discharge meetings, whenever we wrap the entire care team around the client to ensure they have a very supportive, soft landing back in the community after we had an inpatient stay. And this includes anybody from our internal team. Sometimes we try to incorporate their PCP, nurses, family members, really whoever we can to help support them and ensure that they are getting back into the community, they're safe, we're getting back down to pre-crisis levels. Integrated treatment team planning, and this includes making sure we're wrapping in our therapists, med providers, external entities. Sometimes, a lot of times, if we have individuals who are engaged with criminal activities previously and now they're navigating that system, POs are often involved, just to help everybody stay on the same page. And then some other things we do is we assist for clients who've made no contact. We step in and make engagement activities. We do what we can to make sure that, like, we're reaching out to them, we're sending letters, we're making multiple attempts, and just seeing what we can do to get them engaged in services, especially if they're referred over. We, as an agency, have provided inpatient admission and discharges, and that comes from our crisis department. They send out notifications for every single time we have an admit or a discharge to an inpatient facility, and that goes to the entire treatment team who's serving that client, as well as the appropriate management associated with those staff members to make sure that it's kind of wrapped around. Some other care coordination process and activities include caseload review and assessment, referral of follow-up activities, primary care screening and follow-up, appropriate referrals, treatment team plan or treatment planning, all the things that go with it. And then we'll go to the next slide. Really, this is just a quick overview of how most of our long-term consistent services are structured. So we have crisis department, which is not represented here, but normally we don't have people who are engaging in crisis often. It's normally more of an immediate intervention. So primarily we provide clinical, community support services for adults, community-based services for children. Both of those include case management, peer support, attendant care, TCM work, as well as healthcare services, which includes our medical department. And in each one of those, we've developed a care coordinator at the middle. And then if you'll go to the next slide, I'll actually show you how we determine who that care coordinator setting in the middle of that is. So this is what we spoke about before. Whenever I say if everyone, like whenever we expect everyone to do the work, no one does the work because we don't take responsibility for it. So we created an internal workflow that actually asks questions like, hey, is this person, so we have service members, veterans, and family members. So we have an SMVF patient navigator. So if we have a veteran or their family come through the door, they get somebody who's specifically helping them navigate the VA. And that he is assigned with everything else, but he also consults on cases we have as they kind of pop up. Oh, sorry. With our care coordinators, it's kind of across the board. I just saw that message pop up. But all of my care coordinators come from multiple backgrounds. They're primarily bachelor's level staff. I have some nurses. I have some people who previously worked at state hospital. I have teachers. I have currently 9 people who work for me, and they have kind of a varied background. I have one person who's been with the agency for 25 years, and she's a delight, and she's retiring next year, and I'm heartbroken. But we kind of have just a handful of people from wherever, as long as they meet the case management level, bachelor's level ability of care, they are eligible for the job. And honestly, some of those unique backgrounds, such as previously working, like I have somebody who did I don't want to say 10-year stint, that sounds like they went to jail. They had a 10-year career at the state hospital at OSH as a tech. And then they came and worked for me, and that brought a lot of experience into helping manage crisis as well as inpatient discharges and getting them back to the community level. So some next questions after we go, is this person a veteran or not? Do they need assistance specifically with veteran matters? We go, hey, is this person CBS or CSS? And these are our adult and children services. We have entire teams that are dedicated to providing specific care to these community-based services because there is a higher level of care. These teams are also working around my staff. I've worked to get down anywhere between like 30 and 50 people that they provide care coordination to. So they have smaller caseloads and they're able to provide those immediate needs and not have these, it used to be like 100 per person. And that was unrealistic for the kind of care coordination that we want to move towards. And then just internally, we have, if they're not engaging in either CVS or CSS, we talk are like, hey, are they in medical? Are they in outpatient and medical? Are they med only? And then we also discuss if they're in ACT. And then we also have provisions here on the side for if they're in CDS. We have a hospital liaison who also acts in unison with our other care coordinators to provide integrated care when somebody's in an acute state or being hospitalized. And then on to the next slide. So some of these things we were already having in practice. Some of these things we really had to do some training and kind of shift staff perception on. So some of the things we really focused on are going to be things like care coordination. Laura, like you talked about, care coordination is no longer limited only just to targeted populations. We provide care coordination to every single person who walks in our door, no matter if they're SPMI or SED. Those clients certainly do get probably a higher level of care coordination based off their needs as appropriate. But if you walk into a door, you're probably going to get care coordination unless you literally walk in and turn around. So we also have really pushed that like care coordination can occur as an independent service or activity such as targeted case management. However, it can also occur within the context of part of another service, such as traditional case management activities. Also, care coordination can be a primary job role. We have about 4 job roles in our agency that provide specific care coordination roles, and there's about 2 or 3 dozen people who fill those roles. And those are going to be integrated health specialists, targeted case managers, patient navigators, and crisis liaisons. And so it can either be that primary job role, or it can just be an expectation that we've really integrated into other job roles, such as case management, nursing, therapists, support staff. We do note that treatment plan is a care coordination activity, but care coordination activity should never be limited to treatment planning. That used to be a huge part of TCM. We've kind of moved away from that and more into holistic integrated care coordination provision. But treatment planning is still a pretty substantial piece of it. And then we've also really pushed that some care coordination activities may need to be captured in non-billable services, processes, and activities. Just because something isn't immediately financially viable doesn't mean it's not meaningful and worth doing for the people we serve. And then on to the next slide. So just to give you all kind of an overview of patient navigators, who are going to be specifically our care coordination specialists. This was one position that was really created and dedicated to CCBHC care coordination. So they are the people you see whenever you come into a med appointment or an outpatient appointment. At the second after you do your intake, your therapist actually walks you down and does a warm handoff to your patient navigator. And then they perform your outpatient primary screening and referral. They do caseload management for both their outpatient and medical staff. They track our inpatient emergency rooms. We actually work as an agency and have access to KHIN Conda dashboards to track local hospitalizations and what people are hospitalized for, as long as we share them in our client base, as well as providing presumptive eligibility Medicaid applications for children, mothers, and caregivers of caregivers of children. And then patient navigators actually have helped us fill some of those gaps that were previously not provided in those historical target populations. So they're going to be anybody who walks through the door and has a therapist is now going to have a patient navigator to help them process through our system and help them navigate. Medication services only, and then we also have a patient navigator who specifically works with our veterans, and if they only need assistance for veteran care concerns, they can access us and get consideration and help for only veterans care coordination concerns. And then on to the next slide. So this is something that our patient navigators do, but also it's all of our care coordinators agency-wide have started screening for social determinants of health. This is another one of those things where if you walk in and you access an appointment, you're probably going to receive this screening. We had previously used an internal tool that we had developed, and that kind of initially had addressed housing, transportation, access to health insurance. And then we had turned that around and used that in our community needs assessment. After we got our community needs assessments back, we've actually adopted the WellRx screening tool. And then we've actually added additional measures onto that, including access to health insurance, access to primary care, and the negative impact of social media that were specifically identified in our community needs assessment. And then on this, if you do have positive screens where it asks hey, do you have food? Are you employed? Do you want a better job? Are you safe? Do you have your utilities paid? If they say no to any of those, which would be a positive screen because it's identifying a need, we go through and we have referral expectations and follow-up expectations with each one of those. And then on to the next slide, and we'll talk a bit about not only our patient navigators and some of those screenings, but how we've worked to really develop some of our special populations and integrated teams to serve those clients. We have right now about 4 special population teams that are serving clients in a very kind of integrated wraparound way. That's going to be our assertive community treatment team, which is just about your traditional ACT model, where it's going to they have their own med provider, they have their own case manager, attendant care, peer support. However, they do also integrate some of their clients into our day program so they can get some of those day-to-day life skills. We have our service member, veterans and family patient navigator. His name's Lauren, but not only does he provide care to each of our veterans, he also sets in on team meetings. We include him in wraps, things like that. So if we have veteran specific concerns, we have a veteran who didn't get benefits, we're able to successfully like get them connected with him and get him wrapped into their care and help meet those needs, because it is an entire different healthcare system and an entire different set of benefits. We have early childhood programs, which they have entire teams that include therapy, case management, family-based resources, parent peer support. And then we also have Navigate, which is our team that's integrated into our EES department that works on providing therapy, employment, and education support, case management, and medication access for clients experiencing their first episode of a diagnosis that includes psychosis as a factor of it. It can be schizophrenia, it can be major depressive with psychotic features in between the ages of 15 and 35, and provide meaningful intervention before they have that big first like episode where they lose a job or have issues with school, and make sure we're kind of providing preemptive support. And then next slide. Sorry, I keep hitting my front button like it's going to move for me. This is another one of those things we talked about before, where it's strategic partnership considerations. Establish meaningful agreements. Like, that's the goal. Like, we want to make sure that we're building out these relationships, especially in rural areas, just because you really are going to be able to have not only be able to provide better care, but also have a better view of what the actual gaps in service are that are not being met by other agencies. The first step of that is going to be identifying who. So primary care, veterans, law enforcement, hospitals, community population, homeless shelters, sometimes churches, especially during the winter whenever we're having warming centers. And part of this comes with like setting up preliminary meetings, identifying mutual goals, establishing roles and responsibilities, and then also consider having separate agreements for care coordination protocol. I will say with all of this, the relationship is always going to be so much more important than the document. And then go ahead and skip to the next slide. I will just talk briefly on this. We do have 2 FQHC partnerships, one of which is co-located in one of our buildings and one of which we are co-located in one of their buildings. We have referral protocol for both ways. We have staff are actually cross-trained on how to access service across both of them. And then we are actually piloting a closed referral loop program in one community. And we also go over with both sides of that how to access care for everybody and make sure they know, like, here's what you need to access care, here's how to schedule admission, sliding scale. I will say, despite those relationships that we have built with them, we still will always honor patient choice and what they have already established and connected in their communities. We do have our patient navigators establishing relationships with primary care clinics, and we focus really on making things easy. Simple referral, admission procedures, and then how to communicate. Okay, well, looks like we're at 156. If you will we can skip to the last slide and then I can wrap it up and we will go from there.
That's perfect. Thanks, Sam.
No problem. Can we skip one more? It'll be lessons learned. So with this, the biggest things that we've taken away from this, or start by evaluating when, where, and how care coordination is already happening. Memorialize and often celebrate what you're already doing and the work that your staff has been putting in. Develop a communication plan and follow up often. Written workflows, you have to have them for everything, but also people will not read them sometimes. So making sure that we're training, reviewing, and retraining. Making sure we're sharing data, but not too much data. The where, what, when, who is always very important, but we always want to focus on the why and share that narrative. And then making sure that your integrated care coordination is involved in your continuous quality improvement plan across the board. And that's all I have for today.
Well, that's great. Well, thank you so much, Sam and Laura, for all of that wonderful input today. It looks like we all had so much to say that we went a little over our time. but just really think that it was so important to hear all of that from you versus the breakout. So we'll have to nix the breakouts for today. But Kat is going to put a link to the Success Center one-on-one inquiry. If you want to have a conversation one-on-one, we could bring Laura and Sam into that conversation as well if there was something that really resonated with you that they spoke to today. So please look for that in the chat. And with that, I'll pass it over to Dara to close this out for today.
All right, thank you, Brian. And I also just want to give everyone a quick reminder that slides and recording will go out, give us about 48 hours for that to be sent out in a follow-up email. So everything that we did cover today, we will be sending that out. And if anyone, of course, has any questions at that point, you can also submit those questions through email to connect to us all. So I'll quickly run through just some brief announcements. So just for some upcoming events that we are having, we are launching our Prospective Payment System TA series the end of this month, which will run through May. So this will also be included in that follow-up email, but our first session will take place on March 31st from 3 to 4 p.m. Eastern Time, which we will cover an overview of PPS rate setting, cost, and cost reporting. So again, this information will be included in that follow-up if anyone is interested in attending, so you all can register for that event, and hopefully we'll see you there on the 31st. Also, just another quick reminder, I'm pretty sure most people may know by now, but our annual NetCon is coming up, and we will be hosting a NetCon full-day pre-conference CCBHC forum on Sunday, May 4th, which is designed for everyone, state officials, policymakers, CCBHC's advocacy groups, and researchers. So registration for this event, if you're interested in attending, will also be included. If you haven't already registered, will be included in that email as well. Okay, and as always, and Kat did just drop that link for everyone. We do encourage you all to visit our website if you need any support. We do offer one-on-one consultations, just also for any resource or just general questions. Everything can be found on our website. And we do thank you all for joining and bearing with us. We thank our wonderful presenters today, Brian, Laura, and Samantha. You all were great. Again, just thanking everyone for joining us today and taking time and for hanging in there with us through today's session. We do ask that if you could take a brief moment just to complete our end of session survey. It will pop up in a separate web browser once you exit out of today's meeting, but we do also have the QR code here if anyone would like to scan this before you log out today. So I'll leave this up for a few seconds for anyone who is interested in scanning, but we definitely encourage you all to please complete this because this is very helpful as we are continuing to plan for our future events and resources. We do actually incorporate you all's feedback. So it is, we are grateful for that feedback and we definitely encourage you all so that we can include that in our future planning. Okay, so I'll give it a few more seconds for anyone scanning QR. Okay, and just a reminder, it will pop up in a separate web browser as well. And I'll also send a link in that follow-up email for anyone who may not get to it today, just as a quick reminder. And with that, since we are a minute over time, I'm pretty sure everyone either needs to get back to work or just has general things that you need to get to. So again, we thank you all for joining us today. We hope to see you in our PPS session the end of this month, but also next month in our next new demo site, and that information will go out soon as well. So have a great day, everyone. Thanks for coming.